Hello everyone, welcome to my YouTube channel. Today I am going to talk about chronic compartment syndrome, part 3 of compartment syndrome video. Before we start, there is always a disclaimer, and this disclaimer is the same in all my videos. Thank you. Now let's begin. What is chronic compartment syndrome? It is an exercise-induced condition characterized by reversible ischemia to muscle within a muscular compartment. Symptoms subside when the offending activity is stopped, but return when the activity is resumed. What is the pathophysiology of chronic exertional compartment syndrome, CECS? 1. It is due to marked increase in tissue pressure within the confinement of a closed facial space during exercise. Muscle volume can increase up to 20% of its resting size during exercise. Increase in the muscle volume can cause an increase in the internal pressure within the facial compartment. Number 2. Another pathophysiology is due to local metabolism of the muscle, whereby muscle unable to clear the metabolic waste product fast enough. Patient will present with recurrent pain and disability of the affected muscle and nerve. Why there is a pain? The pain at the affected compartment occur during exercise and relieved by rest. One of the theory of pain is due to rising intracompartmental pressure that cause impact muscle tissue perfusion. Deoxygenation of muscle results in increased cell permeability, causing a shift of fluid into the interstitial space. Compromise of the microcirculation leads to ischemia and pain. What is the risk factor for chronic exertional compartment syndrome? A. Usage of anabolic steroid and creatinine, which increase the muscle volume. B. Eccentric exercise. There is a decrease in facial compliance. Eccentric exercise is a slow, lengthening muscle contraction for a specific muscle. Example, lowering into a parallel squat position in a squat. C. Unusual biomechanics in a runner, such as rear foot landing or overpronation, that can lead to compartment syndrome of the affected muscle due to differential weight loading and pressure on the individual muscle group. Symptom and sign of CECS. 1. Pain in the compartment of the leg at the same time, distance, or intensity of exercises. Pain and tightness resolve after a rest period. It can occur bilaterally. 2. Numbness and tingling in the dermatomal distribution of the affected nerve. 3. Patient will complain of weakness of the affected muscle. Physical examination of CECS again is done after patient complete the exercise that reproduce the symptom. 1. Pain on palpation of the muscle involved. 2. Pain with passive stretching of the muscle. 3. Firmness of involved compartment. 4. Palpation of muscle herniation through defects in fascia that can occur around 40 to 60% of patients. The herniated muscle is palpated over anterior tibia. Facial defects occur at peroneal nerve exits from lateral compartment. 5. Gait or gait analysis will show a pronation of foot. 6. Weakness or numbness of the affected muscle. Example, a weak dorsiflexion shows anterior compartment is involved. Weak eversion shows the lateral compartment is involved. Weakness on plantar flexion shows the posterior compartment is involved. What is the differential diagnosis of chronic exertional compartment syndrome? 1 is medial tibial stress syndrome, MTSS. 2. Stress fracture. 3. Fascial defects. 4. Nerve entrapment syndrome. 5. Popliteal artery entrapment syndrome. 6. Spinal claudication or vascular claudication. So, how do you diagnose a chronic exertional compartment syndrome? The gold standard is the measurement of the intracompartmental pressure. The resting pre-exercise pressure is usually less than 15 mm mercury because the normal pressure is around 5 to 15 mm mercury. Immediate 1 minute post-exercise shows more than 30 mm mercury. Post-exercise pressure more than 5 minutes will show more than 20 mm mercury. Post-exercise pressure at 15 minutes will show more than 15 mm mercury. For radiological investigation, apart from bone scan that could help to rule out stress fracture, MRI is helpful. In MRI, it demonstrates a T2 weighted signal intensity within the involved muscle. The increase in T2 signal shows an increase in the intracompartmental pressure. MRI suggestive shows the muscular edema, muscular swelling, fascial thickness, and fatty infiltration of the muscle. MRI is sensitive but not specific. Infrared spectroscopy measured oxygenated and deoxygenated blood in the muscle. Measurements are taken pre and post-exercise. In chronic exertional compartment syndrome, there are delayed return to the level of oxygenated blood at baseline when muscle is measured post-exercise, and there will be an increase of ratio of deoxygenated to oxygenated blood muscle post-exercise. Management of chronic exertional compartment syndrome can be divided into conservative or surgical treatment. For conservative management, things that could be done involve in eliminating or limiting the offending activity, and the patient become more educated about chronic exertional compartment syndrome and the risks involved. Treatment options include prolonged rest, modifying offending activities, altering training regimens, and deep massage. For surgical treatment, it involves a decompressive fasciotomy, either via open fasciotomy or subcutaneous fasciotomy. Advantage of open fasciotomy are full visualization of the compartment and able to excise the strips of fascia to decrease scarring and reoccurrence. Subcutaneous fasciotomy involves 1 to 2 small incisions. Higher failure rate by subcutaneous fasciotomy method is due to A. Incomplete fascial release, B. Iatrogenic nerve injury, C. Unrecognized fascial defects or muscle herniation. Patients are encouraged to do range of movement exercise and weight-bearing exercises immediately after surgery to prevent adhesion and scarring. Cycling and swimming started as soon as the incisions are healed. What is the risk factor for failure of fasciotomy? It includes A. Incomplete release of fascia, B. Poor rehabilitation, C. Overactive scarring, D. Patient non-adherence to instruction. Okay, we already covered regarding chronic exertional compartment syndrome. Next, additional question that can be asked during exams. Number 1, first question. why there is a risk of compartment is higher in the proximal tibia rather than distal tibia? Because there is a presence a lot of muscle bulk at the proximal tibia compared to the distal tibia that contain more myotendinous junction. When there is an injury, the risk of bleeding is higher in the proximal tibia, that this could raise the intracompartmental pressure that would lead to compartment syndrome. Another question, number 2. In patient post-CMR and above elbow plaster of Paris or long cast who sustain a fracture distal end radius, then this patient, day 2 post-CMR, develop compartment syndrome. So how many percentage of pressure reduction that will occur after the plaster of Paris or the long cast is by valve? So any takers, what would your answer be? The answer is by valving a long arm cast or above elbow plaster of Paris, it significantly reduces the cast pressure. By univalving the cast, it can produce a 60% reduction in cast pressure. By valving the cast, there would be around 80% reduction in cast pressure. By releasing the underlying cast padding, it produces another additional pressure, around 10%. So the last question. If the compartment syndrome of the leg is detected more than 24 hours, would you do a compartment release or fasciotomy? What is the release? What is the reason for your answer? So, please tell me my answer. An ideal time frame for fasciotomy is less than 6 hours of injury. It is not recommended to do fasciotomy more than 24 hours because there already an irreversible damage to the muscle and nerve that already occurred. The fasciotomy procedure is not going to be beneficial. It will cause more harm by doing fasciotomy because incision made will expose the underlying ischemic muscle to external environment that will aggravate infection. If the infection is rampant, patient might need amputation in the leg later. I am planning to cover regarding Volkmann ischemic contracture in another video. I hope that the video is beneficial in your learning progress. See you in the next video. Take care and bye.